do good surgeons make bad decisions? I am Dr. Uttam Shiralkar, a surgeon and psychiatrist based in England. The last video focused on how, despite being seen by experienced surgeons, a doctor did not get satisfactory surgical treatment for the problem of his hand. However, that was only the first part of the story. This video covers the remaining part, which is about meeting between Dr. Groopman, the patient, and Dr. Terry Light, hand surgeon, and former president of the American Hand Surgeons Association and the American Orthopedic Association. That conversation between Dr. Groopman and Dr. Light were enlightening. You might wonder why it would be enlightening when a dissatisfied patient meets with the surgeon just to complain. Please watch the video until the end to find out why I say it is enlightening. First, Dr. Groopman met with Dr. Light not to complain about his experience as a surgical patient, but to analyze and understand why the problem occurred. In other words, it was about why even good surgeons sometimes make bad decisions. Both of them viewed Dr. Groopman's experience from different perspectives. Let's be honest. What happened with Dr. Groopman is not unheard of. We all know that diagnosis can go wrong and patients do receive inappropriate treatments. And when that happens, it becomes a matter of investigations which may escalate into medico-legal case. In some cases, media also get involved. It is common for patients in these situations to blame the surgeons. But this patient, Dr. Groopman, wasn't interested in doing any of that. He knew that the three surgeons he visited were knowledgeable and competent. They had access to advanced technology and all the latest information. Their integrity was not in question, yet they did not get it right. So, when Dr. Groopman began by asking Dr. Light, why did the first three surgeons miss the diagnosis and advise the wrong surgery? Dr. Light's answer was short. He said, because those surgeons were biased in their thinking and they made thinking errors. During the rest of the conversation, Dr. Groopman and Dr. Light displayed a remarkable insight and wisdom by analyzing the incidents as a learning opportunity and what we can call a constructive criticism. Dr. Light explained that the first surgeon made a thinking error due to what is called as commission bias. This type of error causes us to take action when we perhaps shouldn't. Despite various investigations and treatment over more than a year, Dr. A was unable to make a diagnosis or provided symptomatic relief to Dr. Groopman. When confronted with Dr. Groopman's frustration, Dr. A came up with some non-specific diagnosis and proposed very unconvincing surgical treatment. We do see that some surgeons are more inclined to recommend surgery, and some do so because of such commission bias. They operate on cases that others might not. However, surgeons can be influenced by commission bias when they are desperate. Sometimes this desperation comes from pressure from the patient, which happened in this case. Next, Dr. Light discussed the second surgeon, Dr. B, who made a wrong decision due to search satisfying bias. After seeing Dr. Groopman's MRI, he recommended 3 surgeries, each spaced 6 months apart. He thought that he observed 3 different findings on the MRI scan. Instead of considering the commonality among the findings, he stopped thinking after seeing something on the scan. Search satisfying bias occurs when you feel satisfied and stop searching after finding a solution, even if it is not the correct finding. Your solution or your finding may not be correct, but you remain satisfied with your thought process, believing you have found the correct thing and correct solution. An interesting comment or interesting quote in radiology about this kind of biased thinking is, do you know which fracture is missed most commonly? The answer is the second fracture. In case of Dr. B, he identified 3 different pathologies on MRI, which led him to believe that he has pinpointed the problem that requires 3 different surgical procedures. He was so blinded by that biased thinking that he even didn't consider whether the patient feels the problem is severe enough to undergo 3 procedures. The last surgeon recommended arthroscopy based on the information given by his assistant and by seeing the scans. He did not speak a single word to the patient to understand what his thoughts are, what his expectations are. This was a serious communication error. The worst part was that Dr. Groopman tried to understand Dr. C's plan by calling him back and asking a reasonable question. But Dr. C dismissed him with a curt reply, "Leave that to me." Instead of that blunt reply, Dr. C could have explained the reasons behind his decision to perform an arthroscopy, what he expected to find during the procedure, and what his plans would be based on those findings. After discussing the biased thinking of first 3 surgeons, Dr. Light also praised the out-of-box thinking of Dr. D, the 4th surgeon. He was impressed to see how Dr. D avoided the thinking errors by not getting trapped in what previous surgeons thought. He kept his mind open, did not rely solely on their judgment or sophisticated investigations, the results of which Dr. Groopman had with him. But Dr. D applied some fundamental thinking rules, like comparing the anatomy between symptomatic and asymptomatic hands. Dr. Groopman was, of course, pleased that he finally found a surgeon who did not commit any thinking errors. But still, asked Dr. Light, "You revealed the thinking errors surgeons made and the last surgeons avoided them. But the question still remains, why the surgeons differ so much in their decisions? Not only they think differently, sometimes they are very wrong, even those who are known to be good surgeons." Dr. Light's answer was enlightening. He said, "Because we are not taught how to make decisions. We learn to make decisions mostly by observing others, especially the senior surgeons. If we are taught decision making at all, it is about what decision to make, not how to make good decisions." We all know that surgery is both an art and a science. This especially applies to decision making. Now, there is a new discipline called decision science, which has revealed the science behind the art of decision making. In the following video, I will share with you how decision science could be helpful for surgical decision making. Please like the video if you found it helpful, subscribe to the channel and click the bell icon. Thanks for watching.